I can discuss about the different situation that you can see that are mainly three. The first is a patient that discover the CML while they are pregnant. That is a challenging situation, and for which a presentation at ASH was done last year, and hopefully this year we are going to be able to publish the paper. Those are the data harvested through European Leukemia Net under the supervision of Ekaterina Chelisheva, that is the doctor that is sharing with me the European Leukemia Net registry. 86 patients that discover pregnancy during CML at onset were reported. And this is a challenging situation because if you discover being affected by CML while you're pregnant, especially in the first months of pregnancy, you should be out of therapy for at least 7-8 months. And not always you're going to be able to do that because you don't have any remission. So you should take into consideration, generally speaking, but specifically in this case, the phase of the illness and the biology of the illness. Is the biology aggressive? Is the phase advanced? Or it's a chronic phase with a low number of white blood cells? If the white blood cells are above 100,000 or the platelets are above 1 million, because those are the values that can interfere with the blood flow in the placenta and can facilitate both thrombosis and hemorrhage at the moment of delivery. So for those patients, it's important to start a therapy, and the therapy that you can start since the first day of your pregnancy, as we already said, is interferon. So interferon can be started at the beginning of the pregnancy. In the registry, we have seen that sometimes interferon is not enough. First of all, because the mechanism of action is slow, but usually you can achieve a complete hematologic remission, and this is enough to go ahead with the pregnancy safely and go through the delivery and then start treatment with TKI. If interferon is not working or you need a more rapid clearance of the drug, as already said, you can use either imatinib or nilotinib after placenta has been formed. The second situation is a pregnancy while there is already an established CML and the patient is already in treatment. And here also you can have three different situations. First, a pregnancy early in CML management with a patient that has not the criteria for entering TFR, meaning that the diagnosis has been done from less than 2 years and you probably don't have a stable deep molecular response dated 2 years. That is the minimum required for entering a TFR attempt. The second is a patient that has a longer story of CML and has been treated for more than 2 years, but she doesn't have criteria for TFR. That is even kind of worse than the first scenario, because you have a patient with an illness that is controlled but not enough to enter TFR, and you have to stop the drug anyway. And the third is the easiest one, patient that has been treated for more than 2 years and has criteria for treatment-free remission. And in all those cases, you have to consider the patient singularly, because the PCR can be variable, as already said. Not always the rise of the transcript is going to be quick. The stopping treatment at first pregnancy positive test is valid for all those categories, and then the common sense should guide on what is the best for the patient, considering that you have 3 drugs that you can use: interferon since the beginning, and then imatinib and nilotinib carefully after the placental formation.